to all of you. So a very happy International Thalassemia Day to all of you. We have all seen how well Indian pediatric hematology, oncology group members have celebrated thalassemia across the country. And I think it was really overwhelming to see each and every institution trying their best and to put their best foot forward to celebrate thalassemia and increase awareness about this condition. So a video was made by the PHO chapter, which has been sent to all of you by a link. And I hope you will see this video. We endeavor to, translate this and send the message across to each and every state of our country so that the awareness message through PHO chapter is spread far and across. So thank you for joining in. Thank you, Shruti, for inviting our guest speaker today. We are very, very excited to have Dr. Ali Ahmed here to hear about alpha thalassemia. And, we always talk of beta thalassemia, and we never talk about alpha thalassemia. And I think it's the right time to talk about alpha thalassemia and learn more about that. So, Shruti, over to you. Please take the webinar forward.
Sure. Thank you, Manas. So as all of you are aware that every year International Thalassemia Day is observed on 8th of May in the loving memory of George Anglissos, the son of TIFF president and founder Panos Anglissos, and all patients who are no longer with us. As this year's theme was empowering lives, embracing progress, equitable and accessible thalassemia treatment for all. And it underlines the need for addressing patients' rights to access to all available, approved, and safe treatment options. As Manas just said, we always talk of beta thalassemia, but alpha thalassemia, the gene is, about 5% of world's population is a carrier of alpha thalassemia gene, and more than 1 million patients with alpha thalassemia syndromes are there. And these are often ignored, underdiagnosed, undermonitored because of lack of awareness, not just amongst the patient, but also amongst the physician. That's why in 2023, TIFF released its first guidelines on alpha thalassemia to raise awareness regarding the disease. And, and it was under the leadership of Dr. Ali Ahmed. Dr. Ali Ahmed, who's the guest speaker for today. Sir, thank you for joining us. He received his medical degree from University of Tehran of Medical Sciences, completed pediatric residency from University of Calgary, did a pediatric hematology oncology fellowship at University of Ottawa and University of Toronto, and subsequently did a clinical and research fellowship in hemoglobinopathies and iron overload disorders at Hospital for Sick Children, Toronto. Dr. Ahmed's area of interest are, of course, thalassemia, sickle cell, iron overload, as well as thrombosis. And he's a principal investigator in Intercontinental Thal Study, which is an international collaborative research study in thalassemia. So here we are, ready to hear about the guidelines for management of alpha thalassemia from none other than the author of the book itself. So I won't, stand between you and him anymore. I would hand over the proceedings to Dr. Ahmed to take it forward. Thank you, Dr. Ahmed, once again for joining.
Thank you so much for having me. I'm honored to share this with you. The reality is that I'm kind of grew up from your neck of the world, like in Asia, but the reality is that I've learned from you everything, and we just put things together. So I'm excited to learn even more from you with any discussions. So I just wanted to share my slide. I think, oh, this is not the right one. Okay, so do you see my slides?
Yes, Dr.
Perfect, excellent. So thank you so much for having me, and I thought this is also a good opportunity to discuss the management of alpha thalassemia with the new guideline that we developed. So to begin with, I do have some conflict of interest to report. Nothing really related to the discussion that we are having. These are mostly related to hemophilia, some advisory boards that I've set. So why the new guidelines? I think, as Dr. Takar put together, this is really alpha thalassemia is quite common, maybe probably more common than beta thalassemia worldwide. It is definitely because of the area that is really populous in Southeast Asia and East Asia. But in general, the knowledge about it is very limited. In areas that there are not a lot of alpha thalassemia, practitioners may think that alpha thalassemias are like beta thalassemia, or they're quite a benign condition, and generally approach them either ignore them as a kind of a condition, or on the other side also they think that their management is exactly like beta thalassemia. But there are quite differences. As you know, hemoglobin H disease is the most common clinically significant alpha thalassemia, but there are important pathophysiological and differences in the outcome, necessitating the different approach to these patients. Similarly, for alpha thalassemia major, which is currently a rare condition, but can potentially be a really important patient group in the future with advancement of care and survival of the individuals, and also other more severe type of hemoglobin H disease that are transfusion dependent. It is generally thought that their care is exactly like beta thalassemia, transfusion dependent. But again, there are important differences in their pathophysiology requiring different approach. More importantly, also within the hemoglobin H disease group, there are diverse pathophysiology. Again, they require different approach for each of them. And also there are some limitations because, again, either thinking that this is like a beta thalassemia or thinking that this is not as clinically important as beta thalassemia, there's really a paucity of data that are available to really offer treatment for these individuals. I think once we get together, we really thought that really to approach the individuals with alpha thalassemia, you really need a fresh look in management and more specialized management for their treatment. So just very brief review. As you know, alpha thalassemias, like beta thalassemias and other red cell disorders, they're evolved through adaptation to severe anemia. Here you can see that it is exactly the same as beta thalassemia, as we say in the thalassemia belt. But I would like to highlight that the important from the clinical perspective are the ones who, the epidemiologic wise, are the ones who areas that have alpha 0 thalassemia, meaning they have 2 gene deletion. Because if an area is very common just to have an alpha plus thalassemia, meaning 1 gene deletion or mutation, it probably won't be associated with any clinically significant disease. But if you are in an area that has large number of alpha 0 thalassemia, then that would be clinically important, because that will develop to hemoglobin H disease, or also possibly hemoglobin Barrett's hydrocephalus. And to approach that, I think we all know the first step is really the CBC and smear. If you don't have a reduction in MCV or anemia, then you can confidently say this is not alpha 0 thalassemia carrier. But if you really want to approach it from a perspective of diagnosis or population screening, then the next steps, if you meet the criteria of macrocytosis, then you have to really look into genes. And depending on where you are and the common mutations that are usually, there are predefined and pre-made PCR kind of approaches. And then beyond that, then you really have to look into different methods to really identify individuals with thalassemia. So you all know better than me, from the alpha, from chromosome 16, you make alpha gene, alpha globins, and from chromosome 11, you make beta. I wanted to highlight that unlike the beta thalassemia, which usually becomes significant after the switching from fetal to adult hemoglobin, alpha thalassemia depends on the severity of them. They're meaningful very early on, from the embryonic to beta gene switch to the fetal, and then later on to the adult switching. So it's what kind of a simplified, pragmatic look at how this works, you can see that if everything is good and cohesive in an adult, you can see that from the alpha globin cluster, you only make alpha globins, but from the beta cluster, you make a little bit of the delta, predominantly beta, and all together, once you have a very well-balanced production of the alpha-like and beta-like globins, you form exact amount of hemoglobins tetramers that are predominantly hemoglobin A and a minute amount of hemoglobin A2. So there is nothing left, there's no imbalance, and everything works in unison and in perfect shape. So this is an individual with no thalassemia. But when you're looking at the alpha thalassemia, just a quick look at the genetic basis of it, I think the normal individual would have all 4 alpha genes intact. But when, as a carrier, this individual may not even be noticed on the CBC. They won't have microcytosis, they won't have anemia. That you can be either missing a gene or have a mutation in one gene. This has no clinical significance. Again, the only time that it is important if that comes with in terms of the family planning with someone who has a deletion of the gene, the 2 genes on the other side. Alpha thalassemia minor is really when you have 2 genes that are deleted. And it can be in trans or it can be cis. And really these cis ones are the ones that are important for us to identify, again, for family planning for the future. And to identify really these individuals who will have hemoglobin H disease. And depending on the type that you inherit this hemoglobin H disease, the severity can be different. So you either will have 3 gene deletion or you have a 2 gene mutation. So the mutated genes, in addition that the production of the normal alpha globin is lost, they also produce an abnormal hemoglobin, and that abnormal hemoglobin depends on its property, may be either unstable or may damage the red cells or may cause ineffective erythropoiesis. So generally a mutation is a little bit more severe than just having a deletion. And on the more severe spectrum of these people, it would be what we call non-deletional hemoglobin H disease. And those are the ones that, in addition to missing 2 genes, they will have a mutation on the other gene. These individuals can be transfusion dependent and generally considered, depends on the type of mutation, a little bit more severe type. And of course, the most severe form is hemoglobin H, hemoglobin Barr's hydrosphettalis, that you have really no functional alpha globin. And then due to that, and if you remember very early on, at the embryonic to the fetal phase, because you're now switching to alpha, if you don't have it, this is incompatible really with life without really offering intrauterine transfusion. So the main focus of the alpha, the guideline, of course, is on the most common clinically significant condition, that is hemoglobin H disease. So, as we talked, this is the most common clinically significant, and we already discussed about how you're going to inherit that. And as I said, it is common in area that you have at least have 1 alpha 0 thalassemia deletion, meaning 2 gene deleted from one side. And although you can see here in this map that it runs around the whole globe, in the thalassemia belt, but really the areas of interest are the ones that are alpha 0 thalassemia, and that is Southeast Asia and also Mediterranean, more close to the Cyprus. But with migration, this condition is not anymore just dedicated to those areas. Here in Canada, you may be surprised, we have a lot of individuals with hemoglobin H disease. So although there are a lot of overlap really between these 2 types of deletional versus non-deletional, there are quite important differences in their pathophysiology that we would like to highlight. For that reason, I think just reporting outcomes on doing research on global hemoglobin H disease is probably would become more confusing. So if we are really to do a research, we have to focus who is deletional and who is non-deletional. That would give us a better idea for future and how to approach these individuals. So for that reason, in the TIF guideline, we really look at these two conditions completely differently in two different chapters. They are cousin of each other in a sense, so there are a lot of similarity, but there are very important differences between the two as well. So the deletional hemoglobin H disease, the more common one and the more milder form of the condition, as you all know, is that you have your beta genes all intact, but on the alpha gene, you only have one functioning alpha globin. And here I just wanted to depict that how it looks like in the cells. And as you can see, your beta globins are producing enough, but your alpha globins are not producing enough. And what will happen is that the amount of alpha that you have will form with the beta some normal hemoglobin A2, but the remaining beta globins, they will form a different hemoglobin that is called hemoglobin H, hence the name. Here, I would like to highlight these important differences versus the beta thalassemia for you. One is that unlike beta thalassemia, that the majority of hemoglobin without transfusion is hemoglobin F in the more severe forms, and hemoglobin F is perfectly functional. Hemoglobin H that you're formed here, and depends on the type of it, the proportion of it is different, has no function. It has really high oxygen affinity and doesn't release the oxygen to the tissue, so essentially it is useless. Second is that, again, unlike beta thalassemia, where the remnants of alpha globins will form an aggregate and destroy the red cells right in the very early phases of the erythropoiesis in the erythroblast, in the alpha thalassemia, these extra beta globins will form a relatively functional, a relatively stable hemoglobin. So although there is some degree of ineffective erythropoiesis, this is different than beta thalassemia. So you will see that this condition is actually quite a hemolytic process as compared to beta thalassemia, that is a condition of ineffective erythropoiesis. You will notice that reticulocyte in these individuals are quite high. Bilirubin is much higher than, let's say, your non-transfusion dependent beta thalassemia patients. So these are important even in their management. So for the deletional hemoglobin H disease, again, as we said, it is a relatively benign condition. And really, should we call it a hemoglobin H disease? When I counsel my patients, I really, right off the gate, I will say that, I'm calling your condition, the name is hemoglobin H disease, but we probably have to come up with a better name to reflect that you are not a person with a disease, because these individuals generally do well. They would rarely require on-demand transfusion. And those on-demand transfusion usually due to acute hemolysis that will happen due to either infection or a surgery or during pregnancy, or due to an aplastic event. It is uncommon for these individuals to require transfusion, and very rarely, quite rarely, they will require regular transfusion. So as I said, because the regular transfusion is quite rare, they don't need also any other intervention. Splenectomy sometimes is employed in people with beta thalassemia and alpha thalassemia, and we will talk about the splenectomy a little bit more later. It is highly unusual that these individuals require splenectomy. But there are two main complications, and one of those are quite significant. The one condition that can happen is the cholelithiasis, and sometimes it needs cholecystectomy. There are different approaches across the world how people would approach this. The way that we recommended in TIF guideline was that really monitor symptomatic cholelithiasis. If you are splenectomized, which is very rare occurrence in these individuals, then it is reasonable to remove the gallbladder at the time of splenectomy, because if now you don't have the spleen, you increase the risk of infection and cholangitis and cholecystitis. But in the absence of having symptoms, probably you don't need to monitor with, let's say, frequent ultrasound or do the cholecystectomy from our perspective. Mind you, a large proportion of the patients would develop cholelithiasis, and it would be just impractical just to take everyone to do the cholecystectomy if there's no symptoms. But more important, and this does happen, and this is probably a very important reason to follow individuals, mostly adults, with hemoglobin H disease on a regular basis, is that they do develop iron overload very insidiously, and then it usually happens after three or fourth decade of life, and it is quite often missed because the process of absorption, because it is not through transfusion, usually the ferritin underestimates the degree of increased liver iron overload. And just by process of having high iron overload on the liver, you may evolve to having this fibrosis and cirrhosis. So really adults, definitely more than 30 years of age, should be frequently monitored for iron overload. As we said, it is a kind of a mild to moderate type of anemia with elevated hemolytic profile. Usually hemoglobin H is between 5 to 15%. And the phenotype is quite uniform in these individuals. If there are significant differences, then you would like to look at the other reason. But on the other side, the non-deletional hemoglobin H disease, as you can see, in addition to missing one side, like a 2 gene in cis, you also now have a mutated hemoglobin, in addition to kind of the deleted part. So here I wanted to depict this for you again. As you can see, there are a lot of beta globins that are uncoupled with the alpha, and they will form the hemoglobin H. Similarly to the deletional one, they have no function. But in addition to that, there are some mutated alpha that depends on the type, let's say constant spring mutation, that are now coupled with the beta and they form, let's say, hemoglobin constant spring. And in addition to that, you now do not have the functional hemoglobin. This abnormal, unstable, or interactions with the membrane, they will now damage the red cells, in addition to not having enough of the functioning hemoglobin, and that exacerbates the severity of the condition. And as we said, there are different reasons for diversity of the phenotype. Depends on the stability of this now variant hemoglobin, its interaction, its type of interaction with red blood cells membrane, heme interaction, or which gene is the affected one. You can have a diverse phenotype. So unlike the deletional form that I said, they're quite uniform in how they present here. You can have really individuals who have not a significant anemia, or individuals that are quite significant that they need very early intraurine transfusion even, or very like the childhood chronic transfusion. Depends on, again, the type, you may have some degree of ineffective erythropoiesis. Because they are generally more severe, there's also more suppressed hepcidin, and there's more advanced iron overload in these individuals. So just to highlight you the diversity that you can see, on one side, I highlighted you a type of deletion that's called mutation that's called hemoglobin Stanley wheel. This is actually quite interesting because it improves the phenotype. Hemoglobin Stanley wheel, when it is associated with normal beta on the other side, as perfectly functional, but when you get it with sickle cell, it actually prevents the sickling process. So it's actually a good mutation to have. Here, the next, you have a hemoglobin G Philadelphia that basically has no effect on the phenotype. So you have it or you don't have it, it's perfectly fine. Interestingly, it is usually in cis to a deletional form of the deletion as well. You will have some that are affect moderately to make the hemoglobin H is a little bit more severe, like the most common forms of non-deletional hemoglobin constant spring, and some other type of deletional that I highlighted here. These individuals would need more transfusions, and sometimes they become transfusion dependent. To the most severe ones, like hemoglobin Adana or Paknam-Pu, that they are associated with significantly unstable hemoglobin, leading to even hydrops fetalis, a condition that we call hemoglobin H hydrops fetalis, in contrast to hemoglobin Bart's hydrops fetalis, and they will require starting transfusion early in the urero going forward and being on chronic transfusion. They are generally considered transfusion dependent. So from the phenotype, again, this is more severe anemia associated with more severe hemolysis and more severe ineffective erythropoiesis for the ones that we discussed that will have significant effect on the phenotype. Hemoglobin H is usually higher. And again, I would like to highlight that in addition to anemia, as you can see, compared to the deletional one, hemoglobin H proportion is higher. And as you recall, hemoglobin H has no function. So if your hemoglobin is, let's say here, 70, although you may think that, okay, or let's say 80, you may think that, okay, this doesn't fit into a transfusion-dependent severity of anemia. Just recall that hemoglobin H has no function, and 30% of the hemoglobin is here is hemoglobin H, so that the really functional part of the hemoglobin is even lower. So here, as you can see, there are much more possibility of outcome in terms of the organ damage and complications. In these individuals, on-demand transfusion is much more common because they get more pronounced hemolysis with triggers, such that at some point we just say, you know, we have to start a disease-modifying therapy like chronic transfusion in these individuals. Spleen is quite larger, and splenectomy has been shown to be effective in improving the hemoglobin. I will talk about this splenectomy later on, but it is also associated with complication like a non-transfusion dependent beta thalassemia. And it really should be a kind of employed, depends on the resources that are available. As we said, there's higher degree of ineffective erythropoiesis with that earlier iron overload is more common. On the top of it, because you may give on-demand transfusion, that hastens the process of iron overload. Cholelithiasis is more common. Growth and development abnormalities are more common. But unlike non-transfusion dependent beta thalassemia, it is very rare to have extramedullary hematopoiesis or leg ulcers. Bony change is rare, but do happen. Endocrinopathies and thrombotic events do happen, mostly, especially in the thrombosis in individuals who have been splenectomized. Deletional one, but more pronounced, higher degree of iron overload to the liver, and hepatic cirrhosis and fibrosis and can happen. And more importantly, also, these individuals, they do require follow-up with the hematology throughout pregnancy because they become quite anemic. They may have increase in hemolysis, and they may need transfusion. There are some increased risk of perinatal outcome abnormalities, like early delivery, premature delivery, IUGR, with the babies of mothers with hemoglobin H non-deletional form. So here we would like to also highlight that because of the diversity of the phenotype, depending on the type of mutation, it is important to really identify the mutation for diagnostic purposes, also for family planning. Aggressive management of the hemolytic events are very important. So we usually at an institution, and I recognize it may be different in the resources, we do admit these patients because the drop in hemoglobin can be quite significant, especially if they also have a G6PD deficiency on the top. So and they may become so anemic that it will have really some negative outcomes with it. So we would treat these individuals more aggressive than the let's say, similar hemolysis in the non-deletional forms. Because of anemia and because of the non-functional hemoglobin H disease, abnormality of growth failure, bone change, these are also common. So not only looking at the hemoglobin or the need for transfusion, if you have someone who is having a growth failure, let's say it's child, or the facial bone abnormality, or delayed in sexual development, if you have a spleen that big hypersplenism, then we will consider those individuals for transfusion. If anemia is less than 7 as a baseline, similar to what you do for the beta thalassemia, but even if it is a little bit higher, but you think there's a significant hemoglobin H proportion in the periphery, then we do recommend studying the non-transfusion. We would comment again that if you can, and I realize that it may not be available in all areas, that we do measure hemoglobin H. This is an early peak in your HPLC. So if you can quantify that, then we will always recommend that you do the functional hemoglobin adjustment and then make that one an indication for transfusion. So a less common form, but important form, again, this has implications for family planning, is that if you have a homozygous non-deletional alpha thalassemia, the ones that they're coming from mutation of 2 genes in trans. So here, as you can see, there are more alpha globins being produced, but still there are some abnormal alpha globins due to the mutation there. And although you have less hemoglobin H, more hemoglobin A, but you do have this aggregates of non-functional unmutated alpha variant, and they do cause some red cell membrane damage and some degree of ineffective erythropoiesis. They are generally considered mild form of hemoglobin H. This is similar to the deletional one. One important thing in these individuals is that they can be associated with hydrops fetalis. We don't know why they develop hydrops fetalis, but curiously, as they may require intrauterine transfusion and some transfusion right after birth, but as they get to 6 months or 1 year of age, they will come out of this transfusion requirement, and they will be basically a very mild form of alpha thalassemia. So if you identify this individual, again, close monitoring throughout the pregnancy is important. They do need intrauterine transfusion, some of them, but then they evolve to a milder form later on. And this is basically what we discussed. As you can see, the phenotype is relatively comparable to the deletional form, but really highlighting that hydrops fetalis due to this homozygous mutational alpha thalassemia. So in addition to really the gene itself, there are also some associated disease modifier that can modify your phenotype. Of course, we talk about the type of mutation, which gene is affected. The haplotype is also important, but whether you have beta thalassemia associated with alpha thalassemia as well, and depends on the area that you are. I assume that in different parts of India, you can have different type of mutations, G6PD deficiency, sickle mutation, beta thalassemia mutation. So all of those can really create associated of beta hemoglobinopathies associated with alpha hemoglobin, alpha thalassemia. So really, those are unpredictable and individualized. In general, having a mild just a carrier beta thalassemia doesn't change things that much. Similarly, you can have different types of red cell disorder like G6PD deficiency, hereditary spherocytosis. Again, they may have some implications for the severity. These conditions are common in areas that you can have in acquired type of anemia, iron deficiency, folate deficiency, vitamin B12 deficiency. So these are the ones that I said, really, if you have a deletional form and then it doesn't fit with what you expect as a trajectory of deletional form, as a uniform form, then you really have to look at different reasons for this increased severity. depends where you are. If you have infections that can trigger more severe form, there are some we are starting to understand some other genes that can play into to the severity, like a KLF1 or ATRX genes. And also in terms of hemolysis and cholelithiasis, you may have genes that involve in the hyperbilirubinemia or genes that are involved in the iron overload. So the most severe form of alpha thalassemia, as we all know, is the hemoglobin Barrett's hydrops fetalis. And then when you have no alpha thalassemia, alpha globin production, here you only have in an adult, if by any chance the adult survives, the fetus survives, you only have hemoglobin H. You could change the beta to gamma, and that would be the fetal form of it. And then you have gamma 4, which is hemoglobin Barrett's. Neither hemoglobin H nor hemoglobin Barrett's have any functions. Again, they don't deliver oxygen to the tissue. So in addition to severe anemia, now the hemoglobin has really no function very early on from the fetal life, so that this is really incompatible with life. But it can be quite common in some areas. In Thailand, in certain areas, it can be up to 10% of the population having this 2 gene deletion. So by default, if you just calculate 1 out of 100 pregnancies may be affected by this condition. So huge burden. And as we are doing better with perinatal care and postnatal care and intrauterine transfusion, we think that there are more and more of these individuals will survive. So it can be a huge burden in the future, especially in areas that are this alpha-0 thalassemia is quite common. It is indeed the most common cause of alpha thalassemia, the hydrops fetalis in Southeast Asia. So these patients, as we said, very rarely, exceedingly rare, but do happen. Some of them, they may be born with some hydrops and then be saved after. But really for a meaningful survival, you need to start intrauterine transfusion, usually before the 3rd trimester. Transfusion should be effective, frequent, such that you offer enough of the hemoglobin that is functional for the fetus to grow and to suppress, essentially to suppress the hydropis. So for this reason, it is very important that you identify these pregnancies early on and diagnose them, or identify at-risk couples and offer them counseling. The counseling should be really meaningful, and it should not be either persuasive to one versus the other, but also within its meaning, also it is really what resources are available. That may be different how we counsel an individual in more affluent part of Canada versus less affluent part of Canada, where they don't have the availability of really offering a lot of extensive care that these individuals would need. Psychosocial support and psychological support is important because this also affects the health of the mother. We have this mirror syndrome, which is essentially mother mirrors the symptoms of the baby, in a sense that the mother will have similar thing to the hydrops with hypertension, ascites, preeclampsia, and can be quite severe and can be potentially lethal. And also for that reason, really, that decision how to proceed with the pregnancy, which there are 3 options basically. One is to terminate the pregnancy early on, offer intrauterine transfusion, should be done very early on. And the 3rd option is just observe and do nothing, which can prove dangerous to mother if that's the case. The delivery and monitoring should be planned in an area that has really resources and expertise in providing care for these individuals. So once they're born, there are similar as hemoglobin H disease, I will highlight the differences. I would like to highlight some differences here versus transfusion-dependent beta thalassemia as well. Because these individuals need transfusion starting from in utero and then right after birth, they are at risk of very early iron overload. And that is quite challenging because this early iron overload requires early iron chelation, and there are side effects to early iron chelation. So it would become quite challenging when and how to start chelation, what type of chelation you use. And we don't have a good answer how to really do it. For now, we don't recommend any early chelation, anything before 1 year of age. It can be potentially associated with major side effect. So we probably should accept some degree of early iron overload, and then later slowly increase the iron overload through the second years to then effective iron load later on. The second thing is that, as I was saying, compared to beta thalassemia, which they don't have any meaningful reticulocytosis because of the ineffective erythropoiesis, and because anything that they make has hemoglobin F, that it is essentially functional and perfectly fine hemoglobin. Here, because of the lack of ineffective erythropoiesis, they have significant reticulocytosis, and because hemoglobin H has no function, that will create a state that when you look at the hemoglobin during transfusion, you actually miscalculate the amount of functional hemoglobin. So you have to really suppress the bone marrow and also remove the hemoglobin H, in a sense, or suppress production of hemoglobin H, endogenous hemoglobin H, to be effectively offering them a transfused and functional hemoglobin. So in general, we would advocate for a calculation of the functional hemoglobin. And if not, then really an aggressive transfusion strategy is required for these individuals. As you can see, what we say is that and I'll talk about it later, that the functional hemoglobin more than 90 and hemoglobin H to keep it less than 50%, together you can consider that these individuals need a transfusion to keep hemoglobin, total hemoglobin, more than 110. Or 11, I don't know how you report in India, let's say 11 grams per liter. Similar to that, because of this non-functional part and miscalculation of the degree of anemia, they have quite degree of abnormality that you see with non-transfusion dependent thalassemia patients in terms of silent infarct, poor growth, and different things like that, endocrine abnormalities. So really this aggressive transfusion is important in these individuals. Second thing is that because of very early anemia and hypoxia, we think these individuals quite commonly are born with congenital anomalies. Almost all males would have genitourinary abnormalities, and around 1/3 to half of the individuals, male and female, will have other abnormalities like digital abnormalities or rib abnormalities. So, and because this happens very early on through the process of organogenesis, there is no meaningful way for us to prevent that because you can just provide this intrauterine transfusion at a certain point and not earlier than that. And that time is, at least based on what we know and what we do here, is much later than this process have already occurred. So they are not salvageable by the early intrauterine transfusion. Because of the burden that this condition creates, it is important to offer curative therapy for these individuals. So another aspect of the care for alpha thalassemias is really during pregnancy. We already discussed this more in individuals with the non-deletional form, but also in the deletional form. So they have to be monitored, and especially the ones with non-deletional have to be monitored in the hematology as well, and they may require a red blood cell transfusion as well. If a patient is splenectomized, then they do require anti-platelet or anti-thrombotic treatment as a prophylaxis. Also, it is as part of the pregnancy process, a preconceptual or perinatal testing is also important for people at risk of having significant hemoglobin H disease or having a hemoglobin Barrett's hydrops fetalis. Because infection is the kind of a most common trigger for on-demand transfusion, it is also very important to manage this. There are alpha thalassemia in several for several reasons, is associated with infection. One is that it is common area that malaria was or is common. Infection can exacerbate anemia and hemolysis itself. The ones who require transfusion may get viral disease, like a transfusion-transmitted viral diseases, and also our approach to treatment, like a deferoxamine or a splenectomy, can increase the risk of infection. So infectious disease is an important part of the management of the thalassemia. We frequently monitor them to make sure they don't have any chronic infectious disease, and aggressively that should be treated. If you are splenectomizing an individual, definitely you need prophylaxis and vaccination against encapsulated bacteria. Depends on where you are. Advocacy for vaccination is important for the endemic infections in the area. And we all, if anybody receive blood products, we do screen for that, and we offer a hepatitis B vaccine as well to anybody who we think they're going to need or has required frequent transfusion. Iron overload also can be associated with reduced immunity, so really important to manage the iron overload itself. Dengue fever can be misdiagnosed or omitted or exacerbate also the hemoglobin H disease. So always consider dengue fever if someone is severely anemic with hemoglobin H disease. As we discussed already, iron overload in both deletional and non-deletional can lead to increased liver iron overload and fibrosis of the liver and eventually cirrhosis. I did have a patient with hepatoblastoma due to severe iron overload with deletional, the mild form of hemoglobin H disease. So it is really important that for all of them, you monitor the iron overload. And as we said, that the iron is the ferritin underestimate the degree of iron overload as compared to beta thalassemia. So transfusion, again, we already discussed. We talked about the indications to transfuse. Here we have the formula that we use for calculating the functional hemoglobin. Essentially, you reduce the total hemoglobin, you reduce the non-functional part, hemoglobin H, hemoglobin BARTs, from your total hemoglobin, and that would be your part of the functional hemoglobin. As we said, for the alpha thalassemia major, we will really look at anything more than 90 gram per deciliter or 9 gram per deciliter, and the hemoglobin H of less than 15. If you can't do this, then a hemoglobin more than 110, 105, like 105 to 110, 10.5 to 11, I think it is also it's a good target to do. For the hemoglobin H disease, and depends on the type of it, is different. If you have a type of non-deletional hemoglobin H disease that has quite significant ineffective erythropoiesis, and really you will know that based on one is how much retic you have, but also you can predict that based on the type of mutation, and that's why identification of the mutation is important. Then you really essentially treat them like beta thalassemia. But if you think that the ineffective erythropoiesis is not severe, and you can approximate that, but how much reticulocytosis you have, then you probably don't need as aggressive transfusion as you were doing for beta thalassemia, because the ineffective erythropoiesis is also creates a lot of burden on the heart as well, on the top of just having the degree of anemia. So we usually transfuse these individuals to keep their hemoglobin more than 8, as compared to beta thalassemia that we do it to keep it more than 9 or 10. So less aggressive transfusion if it is a common hemoglobin H disease that is not associated with significant ineffective erythropoiesis. And of course, you want to make sure that the blood product is good and all the hemovigilance and blood conservation and not wasting the blood. A splenectomy, as we discussed, we try not to do splenectomy as much as we can because there are some side effects to it: thrombosis, pulmonary hypertension, also risk of infection. And we have seen all of these complications in our splenectomized patients, but it is effective. It's a little bit probably less prohibitive to do splenectomy in alpha thalassemia than beta thalassemia. And the risk of this complication is probably a little bit less than in beta thalassemia, because just the function of spleen here is different. The spleen is not significantly contributing to erythropoiesis. It is more just to remove the senescent hemoglobin H cells. So in general, it's not as bad situation if you do with non-transfusion dependent thalassemia. This is also important because if you are in a center or an area that really transfusing an individual on a chronic basis or regular basis may be quite challenging, then splenectomy is a viable option in these patients, more even so that the beta thalassemia individuals. We usually don't do them less than 5 years. We allow them to develop their immunity a little bit more if you have to do it, and definitely we give vaccine, and then depends on the rate of encapsulated bacteria and severity of those in your environment. We may continue indefinite prophylaxis with antibiotic or limited time. We also put them on aspirin if we do splenectomize them because of the risk of thrombosis. Different types and different approaches of the splenectomy. We are not clear which one is better than the other one. If you are to do it, what the evidence has shown is that the total splenectomy is the choice. But if you want to do a partial splenectomy, we don't have any evidence how much they're effective or how much they reduce the complication later on. The iron overload part, I don't go quite in detail of it, but it is available for you to look. We developed this table keeping in mind that different types of hemoglobin H disease have different degree of and different mechanism of iron overload, and also there's significant difference between how iron overload develops in hemoglobin H disease versus beta thalassemia. So our approach was that one, your ferritin may underestimate the degree of LIC. So we really would suggest that you get an LIC. Rarely these patients would load iron into the heart unless they are transfusion dependent. And for that, we suggested the targets for MRI, for the liver iron concentration, but also if that's not available, some targets for ferritin that you should follow in terms of starting it, monitoring it, and discontinuing it. And I think one other important part is that the curative therapy, it is possibly the hemoglobin H disease, the common types of deletion order will never require such an kind of aggressive approach, but maybe the ones who are transfusion dependent with non-deletional form, and definitely the individuals with alpha thalassemia major or hemoglobin Barr's hydrocephalus, they would benefit from curative therapy. Most of the reports are only on alpha thalassemia major, just case reports on the other forms. So it is an important approach in these individuals if the resources are available to you. Again, once we are doing it, we employ what we have learned from beta thalassemia, but we have no idea how different we should do it. We do know that the pathophysiology is different. In the absence of having really a specified approach, we probably would follow what we recommend for beta thalassemia. And the last thing is that also the highlighting to the prenatal screening for these individuals through the process of identifications of the carrier early on, and either through genetic diagnosis to obtaining a DNA from the fetus or the cord or amniocentesis, or really through a non-invasive approach through ultrasound to identify hydrops. Of course, that will not identify individuals who have hemoglobin H disease through ultrasound unless it is a type that is associated with hydrops. And usually the second option, although much more convenient and associated with less risk of intervention associated complications, it just delays the intervention as well. So early diagnosis of individuals at risk are important, and counseling. So that's we would like to highlight that option. Here on the right, you can see a diagram how to use ultrasound going forward to monitor the high drops for these patients. And here, I just would like to also introduce you the new alpha thalassemia guidelines, and I'm really grateful to have me here for you.
Thank you once again, Dr. Amit. I think we have some questions in the chat box. Dr. Vasudev, my colleague, will be taking up these questions with you.
Thank you, Dr. Ali. Very nice presentation. There are some questions in the chat box which I will just open up. So there is a question from Dr. Naresh asking, if carrier is only one gene of alpha chain absent, can they have a normal MCV? And what is autosomal dominant alpha thalassemia?
So if that's correct. So if you basically have only one gene deletion in the absence of anything else, you, by definition, you don't have microcytosis, and that's why we use that process to identify this individual. And that's what makes things a little bit complicated as well, that you may miss common hemoglobin H disease throughout the pregnancy, but also that's not important as well. If you have a one gene mutation, then you do get microcytosis. And if the other person has also microcytosis, again, that means that either you have, assuming coming from alpha thalassemia, not beta thalassemia, then that would make an important hemoglobin H disease, either the non-deletional form or homozygous mutational form or hemoglobin Bart's disease. So that's why we go through the process of whether you have microcytosis in both parents to identify important hemoglobin H disease, not the common non-deletional ones that will probably have no implication for pregnancy and later on in life.
Thank you. Another question is again by Dr. Naresh is, can HPLC help to diagnose alpha thalassemia, or diagnosis requires genetic testing only?
Yeah, so really good question. So HPLC has limited implication in diagnosing alpha thalassemia, but there are sometimes that there's benefit to it or clues from it. For example, HPLC is very helpful to identify hemoglobin H disease at the time, at the prenatal phase, like a neonatal phase, where you still have hemoglobin Bart's, and then you can see the early peak of hemoglobin Bart's, and then if you have, let's say, more than 20%, then you have hemoglobin H disease. You can, in the absence of iron deficiency, you can have a low hemoglobin A2 that would give you a hint that this individual may have alpha thalassemia. It's not diagnostic, but it gives you a hint. Also, at the time that you have mutational alpha thalassemia, then your product is viable enough. You have some that are like a hyper unstable, and you don't see anything on the any abnormal peak on the HPLC. But if you have some degree of viability to hemoglobin, then now you have this mutated alpha globin, and then you see many peaks that comes from coupling of alpha globin that is abnormal with your beta, with your delta, with your gamma. So if you see a lot of peaks in your HPLC, then again, that suggests that there is a mutational alpha thalassemia. Common non-deletional alpha thalassemia, most of the HPLCs, they don't identify those individuals.
On the same line, there's another question. Is there a possibility that characteristic M pattern is not present in HPLC with a child with HPH disease?
Sorry, I didn't understand the question. Can you repeat it?
Yeah, so the question is that, is there a possibility that characteristic M pattern is not present in HPLC in a child with HPH disease?
Cat 6 is M pattern. I don't know what M pattern is.
Uh, just Dr. Shruti, would you want to?
So I think the question is posted by Dr. Priyanka Agarwal. Priyanka, would you like to take this, just clear what you, basically want to
So,
ask here?
thank you, ma'am. So my question was, is there a possibility, normally in HPH disease, we find a characteristic M pattern in the HPLC. Before the HPF is present, there are characteristic M pattern, which tells us in the HPLC that this is HPH disease or gives a clue. So is there a possibility that in any form of HPH disease, this M pattern is not present? Actually, one of my patients, we diagnosed as HPH disease, but on HPLC, the child was completely normal. So that's why I'm asking this question. Thank you.
Yeah. So you're correct. So yeah, I didn't know you call that M pattern. I think what it is, we call it early phase peak. And you're correct. Depends on the type of hemoglobin analysis you do, you may miss that early peak. Some HPLC softwares, they have an extended window, and then you can see that early peak, and some they don't have that window. So in general, it is tricky. It may get missed, an HPH disease, and again, because you have variable degree of hemoglobin H, that peak is variable as well. So if you have only 5%, that may not be picked through the HPLC. So you're absolutely correct.
Thank you, sir.
Another question is, what are the indications for advising medical termination of pregnancy to a mother who has a child affected with HBH?
Yeah, excellent question. So I have to be careful. I'm practicing in an area that there are a lot of resources, and how we counsel families are different than how I think you will counsel your families appropriately where you are. In general, having a non-deletional hemoglobin H disease, let's say if you identify individuals who are at risk, or you identify a pregnancy that is affected by hemoglobin H deletional form, here we probably, the way we approach this is that this is not a significant condition. We will follow you. We will monitor the iron. You may have some gallstone, but it is not a reason to terminate the pregnancy. In Canada, you can terminate pregnancy for no reason. So that's how we approach it here. We are very much patient driven. So we offer this knowledge, and they will make the decision. If you have homozygous alpha plus thalassemia, that's a little bit different in terms of that, again, these individuals may have hydrops and require intrauterine transfusion, but later on, they will become similar to deletional hemoglobin H disease. So again, we offer them this knowledge, and they will choose how they want to process. The ones that we do counsel, and then sometimes they elect to terminate the pregnancy, clearly the ones with hemoglobin Bart's hydrocephalus, but also the ones who have mutational hemoglobin H disease. That, for example, hemoglobin constant spring, or when we talk hemoglobin Adana, once we go through this, and once they review, they may elect to continue or terminate. Again, resources are also important. I think how you employ this counseling, that maybe for me, it's easy to say, I'm going to transfuse you every month. Blood is free, chelation is free. But then in another environment, those resources are not available, and it is significant burden on families, and the healthcare system. So it is a little bit different. But really, I think the gist of it is that the deletional forms, probably they don't need termination of pregnancy.
Dr. Amit, how easily is, intrauterine transfusion available in Canada? And if I'm not aware whether this facility is available in India, if any of the participants knows, they can put it in the chat box so that everybody is aware of, the availability of intrauterine transfusions in the country?
Yeah. So this is a process that same process that you do for hemolytic disease of the newborn. Like if you have a RH incompatibility and then you have anemia, intrauterine kind of anemia, and then you offer intrauterine transfusion. So the process is the same, and I'm sure in India you do in different places. I think maybe in the more kind of larger centers you offer that. There are some differences in terms of how to do it because of the significant hydrops that these patients will be identified with. I'm not a kind of obstetrician, and I certainly don't know the kind of the detail of it, but I do hear that sometimes just process of transfusion, because of how the placenta is engorged and then how the significant hydrops, sometimes it may be challenging. It is not available in every center in Canada as well. There are limited centers that they can offer it. So quite often, if we identify these individuals who are being born into centers that they don't have this option, then they will go to the larger centers that they will do it.
I had another question, like for our non-transfusion dependent thals and our patients who undergo splenectomy, we use these markers like nucleated RBCs and platelet count of more than 500,000 as cutoffs for starting and antiplatelet drugs. So is there any criteria that we can use for starting anti-aspirin or a low molecular weight heparin in patients with alpha thalassemia?
Yeah, really good question. So we put all of them unless there's a complication on aspirin. And the reason for that is that it is not just a platelet that is elevated or just you can calculate based on the nucleated red cells that will tell you who will have thrombosis. At least we haven't figured out who would benefit from anticoagulation or antiplatelet therapy and who won't. Remember that this is a condition that different than non-transfusion dependent thalassemia and different than spherocytosis. For example, they will continue to have some hemolysis. They are still anemic, and they still have hemoglobin H that is non-functional, as compared to someone in a spherocytosis that the red cells are perfectly functional, and now you only have this platelet that you have to look for. So we do put them on aspirin. Do we need to put everyone on aspirin? Probably not. Do I know which one to choose? Probably I don't. Can I guess which one should absolutely be on aspirin? Probably I can. Really, as you know, you mentioned the ones who continue to have a lot of hemolysis, the ones who continue to have some evidence of ineffective therapy, or the platelet is really high. So that was complicated answer. But I think we do recommend everyone to go on aspirin unless there is a side effect. And of course, if it is something that affects the quality of life of the individual, then we may reconsider that. But yeah.
We have one more question. What should be the molecular approach for identification of deletional and non-deletional alpha thalassemia?
Yeah, good question. So I think this is something that we advocate every environment that make that decision for themselves. So in general, and I think in India this would be fascinating with just how much you have and the diversity that you have in your country and movement around over centuries of civilizations. So the way that we look at it is that you probably would be able to identify common deletional and mutational alpha thalassemias in your environment. If with a good degree of certainty that is something that you can do that, then you may start with a common panel, a PCR test of the common deletions and mutations as a first step. That is to identify most, but probably not, patients through a cost-effective process. And then if you have some degree of suspicion that that doesn't answer your question, that, okay, so I think this patient has alpha thalassemia, I did this panel of six common deletions and mutations, there's nothing in this PLC that suggests there's a mutation with the different peaks and things like that, then I think the next step either would be like a PCR or MPLA, that you'd identify the deletions or a new unidentified mutation. So it's a stepwise approach really to go through it. Usually starts with a panel of common deletions and mutations wherever you are.
Thank you. And just one more, I had missed this question. If serum ferritin had good negative predictive value, and if it is kept less than 1,000, then could it rule out organ damage?
Yeah, so really good question. You know, as I said, depending on the type of hemoglobin H disease, and different in individuals, of course, and then you have different mutations in your, like the HFE, for example, hemochromatosis genes. The cutoff to identify iron overload or liver, like significant liver iron load based on a ferritin is very difficult to define, just because of the significant diversity of the process. Not like NTDT in the beta thalassemia, that you have just a spectrum, linear spectrum of more severe, less severe, but the process is the same. So it is quite challenging to offer a cutoff. We know that the cutoff is much less than 1,000 in alpha thalassemia. So if you have a person with NTDT has never been transfused, and then you see the ferritin is 500, you probably have good amount of iron overload. So then you may actually consider doing LIC with the ferritin is 500. When it is 1,000 in hemoglobin H disease that is not transfusion related, I will say this is high enough. So that's why we suggest, and again, it is probably the crazy suggestion, that if you can do the MRI, and that's why we really highlighted different targets for ferritin with all uncertainty of it, that if it is through those levels, then consider doing chelation. Because this is a very insidious iron overload, you probably don't need a prolonged iron chelation as well. So you just chelate, and then ferritin going to go down and you can stop. So we hope that at least from that perspective, we don't over chelate, and then we don't create a lot of burden of the cost of iron chelation. But I think the ideal way is really to do MRI, because that ferritin to LIC ratio, it is highly unpredictable because of the diversity of the condition. The physiology of iron loading in, let's say, the deletional versus non-deletional, and the non-deletional one depends on the ones who are more hemolytic compared to the ones who are more ineffective erythropoiesis. I hope I was able to answer your question.
Definitely, Dr. Amit. I think that's all for the questions tonight, and I would like to thank you from all of our participants for a brief overview of alpha thal. And I believe in our country we have been underdiagnosing alpha thalassemia a lot, but now with the availability of genetic testing, it is becoming easier to diagnose. And as you were mentioning about MRI for monitoring iron overload, MRI is available easily, and we should, especially for non-transfusion dependent thals and alpha thalassemia, we should always, try to get an MRI and not just rely solely on serum ferritin. And I think now onwards, we would be, managing our patients with alpha thalassemia better. And we look forward to, collaborating with you in any further, projects or webinars. So thank you once again for being there for us today.
Oh, absolutely. It was my honor. Thank you so much for having me.
Thank you, Dr. Anand. Good
Thank you
night,
so much.
everyone. Please
Bye,
don't
everyone.
forget to share your feedback. The link has been shared. Thank you.
Thank you so much.
Thank you.